The COVID-19 pandemic made it harder to get healthcare. There were a lot of reasons for this, but new ways for people to see or talk to a healthcare provider were needed. One of the things done to help was allowing telephone and video-based calls between patients and healthcare providers, also known as telehealth. North Carolina Medicaid made a lot of healthcare services available over phone or video-based calls for the first time so that people could get the care they needed during the COVID-19 pandemic. At the Duke-Margolis Center for Health Policy, we wanted to learn how people with Medicaid insurance were using these telephone and video-based calls to talk with their healthcare providers, and if some people had a harder time getting the healthcare they needed than others during the COVID-19 pandemic. In our research, we studied healthcare for these two groups, BH, also known as people with behavioral health conditions, and MSK, people with musculoskeletal conditions, because each group has unique needs, and both conditions affect a large amount of youth and adults. Many people have trouble getting care for their conditions because of limited access to healthcare providers, issues with access to transportation, and/or limits on coverage for specific services like physical therapy in adults. We wanted to learn if telehealth could help people get the care they need. We spoke with healthcare providers to understand how telehealth changed the way people with these conditions used services. They told us that telehealth made it easier for people with MSK conditions to get care, particularly if they didn't have a car or had trouble walking. For people with BH conditions, we heard that telehealth worked particularly well for services like therapy and medication management. Telehealth also helped reduce barriers, like transportation, but it also couldn't replace the face-to-face interaction that some providers thought was important, especially when a physical examination was needed. Some reasons people had trouble using telehealth to talk with their health providers included inaccessibility for people with hearing loss, a need for more interpretive services, what their Medicaid insurance would pay for, whether they could access broadband or the internet, whether they had devices like smartphones to talk with their providers, and whether they knew how to connect to a telehealth visit. After looking at the 200,000 plus adults and children who got care for an MSK or BH condition during COVID-19, we saw that not many used telehealth to access MSK services, but telehealth did play an important role in helping children get physical therapy and occupational therapy. Telehealth was also a popular way to access BH services during the pandemic, especially for people accessing psychotherapy services. We also saw differences in who used telehealth to access such services. One trend that spanned both cohorts is that fewer Black, Hispanic, and multiracial youth use telehealth. Another key trend was that more people with complex healthcare needs use telehealth. As an example, more adult telehealth users that qualified for Medicaid due to disability and had more chronic conditions. With the understanding that telehealth can help people access and maintain MSK and BH healthcare, we can take steps to build on the benefits of telehealth to increase access. We need to think about how telehealth can help people who aren't already well connected to healthcare get the healthcare services they need. Our research showed that people who use telehealth use more healthcare services overall. Another thing we need to keep in mind is that audio-only telehealth, or telehealth without a video component, can play an important role in helping certain groups access healthcare services they need, like people without internet access. We should also consider how payment models that support providers in a hybrid model, where in-person and virtual visits can be used, to deliver high-quality care and meet the needs of Medicaid beneficiaries. And lastly, we need to think about people who can't access healthcare services via telehealth without better broadband internet access, the right devices, and the knowledge of how to connect to telehealth on those devices. So what does this all mean? It means that while telehealth helped maintain continuity of care and access to care for Medicaid beneficiaries, it's not yet mitigating disparities in access to services for historically marginalized groups. If you're a provider, telehealth has been a critical way that people accessed healthcare during COVID-19, but certain groups of people have not yet been able to take advantage of telehealth to gain that easier access. Consider offering telehealth at your organization, and if you do, provide ongoing patient education about what services are available and how they can use telehealth to talk with their providers. If you're a policymaker, it's important to know that certain groups of people have not been able to take advantage of telehealth to create easier access to healthcare. Payment incentives for providers, patient and provider education, and broadband digital access are needed to help more people access the care they need using telehealth. We are continuing to study this, and our more in-depth findings can be found on the Duke-Margolis website and also this QR code here. We would like to thank these people and organizations for their support in this project. Thanks so much.